So good afternoon, everyone, and welcome to the Leadership and Innovation in Long-Term Care 2021 event. My name is Beth Henderson, and I am one of the RN team leads for the Behavioral Support Team. In the past, North Simcoe Muskoka Specialized Geriatric Services Program and the County of Simcoe have been able to collaborate to offer full-day education and networking events for our long-term care home partners and the behavioral support system teams. Unfortunately, our 2020 event past March had to be canceled due to the COVID-19 pandemic. For 2021, the North Simcoe Muskoka Specialized Geriatric Services team has organized a virtual leadership and innovation event. In place of an in-person session, we will be offering 3 one-hour webinars over the next 3 months. Prior to starting with today's event, I have some technical information to share with you. Please write your name and organization in the chat box. And if you have more than yourself at your computer, please include all names of those watching in the chat box as well. Please note that all attendees' microphones are muted and videos are off. You will notice that there is a question and answer tab on the bottom center of your screen. Please feel free to type in any questions for today's presenter, and we'll allow for some time at the end of the presentation for your questions to be answered. We have someone monitoring the question and answer box, so please feel free to use it. Also, please be aware that today's session will be recorded and available following the session. For today's presentation, it's my pleasure to introduce Dr. Geoff Daniel. Dr. Daniel will be speaking today on anxiety in the older adult. Dr. Geoff Daniel is a geriatric psychiatrist working out of Waypoint Center for Mental Health Care for SGS. In Dr. Daniel's 23-year career, he has been involved with 5 different outreach teams in Ontario, including Brampton Civic and Wellington Dufferin Seniors Outreach. His role on the SGS team ensures that geriatric psychiatry is closely integrated with both BSS and geriatric medicine. This collaborative approach to care has proven successful and has offered our residents of long-term care a single integrated system of geriatric mental health services. So I introduce to you today, Dr. Geoff Daniel.
Thank you, Beth. Good morning, or good afternoon, everybody. It's very disconcerting to not see faces, etc., but we will forge ahead. What I'd like to talk today about is really focusing on what you're reading, the anxiety in long-term care, and eventually I'll break it into the person, the older adult with dementia. But first, I just want to talk about how I'm going to structure the hour, hopefully with some time for chat afterwards in terms of questions. So I'm going to start off just reminding us that there is such a thing as normal anxiety. That's not necessarily a bad thing. And then talk about the DSM-5, so that's sort of the latest way we categorize psychiatric anxiety disorders. Talk a little bit about as we age, how might that impact some of these disorders, and then talk about anxiety and dementia. And then there's the placemat that Tamara told me I had to mention or else, but it also is very useful. And so I want to just celebrate that and talk a little bit about how that fits in, and then talk about some interventions. So first, as promised, what's a disorder, what's normal is often a criticism of psychiatry. And I think we have to remember that not all anxiety is abnormal. In fact, anxiety can be helpful. It can be a signal. Actually, Freud called it a signal anxiety, and warn us of things, etc. Or it can be a great motivator. For example, getting one's slides done before 11:55 today. So it can be a useful thing. In terms of the DSM-5, I just put this slide up just for the people that are saying, hey, what's with obsessive compulsive? Where do I find it? It's just some of these disorders have been moved around. So OCD is now under a different category. It's not under anxiety disorder. Same with PTSD, no big deal. And then they've moved the separation anxiety disorder and the selective mutism into anxiety disorder. So that's more for the anal types in the audience, I suppose. The anxiety disorders in DSM, this is basically the list without the last two I mentioned. And I'm not going to go through every one, but that's the list we're talking about when we talk about psychiatric disorders. This is actually for the adult population, but same for the older adult. And then I thought what I'd do is just remind you guys of some of the ones that you hear of, know of. So panic disorder is a cluster of panic attacks. And so it's recurrent panic attacks. The recurrence is unexpected. It's typically out of the blue. It's not precipitated. And then I have the definition of panic attack in brackets there. And so it's that abrupt surge of an intense fear or intense discomfort. It peaks within minutes, right? And then it has the famous cluster of symptoms. And so CVS is cardiovascular, SOB is shortness of breath, just to be clear. So those are the kinds of things that typically people see when somebody's having a panic attack in front of you. The issue then with a lot of the psychiatric anxiety disorders is that then you have the person having a persistent concern or worry that it's going to happen again. And because of that, they change their behavior. They avoid things like certain settings where they think it might, that's where I had my panic attack. Oh my gosh, I better avoid that because I might have another one. So you see a functional impact, a behavioral impact. Social anxiety disorder, also called social phobia, is another one that I'll talk further about in the older adult. But this is the definition as for any age group. And notice that it's about social interactions or social situations. And the essence is that it's a fear of being scrutinized and a fear of being negatively evaluated by others. So one might avoid parties because of the fear of being scrutinized, the fear of being negatively evaluated. It's not because they think that, you know, somebody from the RCMP is in because they shoplifted when they were 13 years old. And sort of, it's not like a paranoia thing, or it's not agoraphobia where they just don't do something because they fear help will not be available, et cetera, et cetera. It's specifically about being negatively evaluated. And again, as in psychiatry, the disorder is defined when it affects functioning. So an avoidance becomes a big issue, as you know, in social anxiety disorder. Then there's generalized anxiety disorder, which is kind of I call it the professional worry wart. And this is excessive, persistent worrying about everyday kind of real life things, routine life stuff. And it's several things. It's not just one thing. It's not like going to the bank because you literally don't have any money or you have this delusion that, you know, you're in poverty. It's not like that. It's not a delusion. It's about real life things, worry, worry, worry. And the worry is not only difficult to control, but it gets in the way of attending to whatever they're doing at the time. They're always worrying. It has a cluster of symptoms that I've outlined there, which are not surprising symptoms. I'll let you read that. And then again, it's a disorder because it causes distress significantly or impairs functioning. So that's the DSM definition of any age with generalized anxiety disorder. Obviously, we need to worry about anxiety disorder due to general medical condition. I've listed some that are known to cause issues. Low O2 SATs, of course. You'll see in the next slide, puffers are the flip side. So somebody with shortness of breath who is anxious, are their O2 SATs low? Are they overusing, especially in the home setting, like their own home, are they overusing their Ventolin and getting all revved up? And you can see other, I mean, there's a ton of them, but this is some that can create anxiety. Just for fun, pheochromocytoma is more linked with generalized anxiety. Mitral valve prolapse is more linked with panic. I guess fun for psychiatrists. Substance-induced anxiety disorder, there's a long list, right? But we have to ask the question, and in the last line, notice, involve the pharmacist, especially long-term care, retirement home. You know, the pharmacist would be very helpful if it's a fair question to say, look, this person's really anxious. I'm wondering contributing to this, could you give me your opinion? That's an important question. I put akathisia as well because that's the motor restlessness classically caused by Haldol, for example. So, in the old days, it would be, person's anxious, oh my gosh, give them Haldol, not a good thing. Oh, they're more anxious, give them more Haldol, and nobody stopped to think, oh, there's actually akathisia. In other words, the side effect of the Haldol is more motor restlessness, jitteriness. And the solution is to decrease the Haldol, not increase it. So that was kind of just the anxiety disorders DSM. And now I want to talk about the older adult, but not yet with dementia. So this is sort of a discussion of, okay, DSM, anxiety disorders, what about when you're older? Well, this is speculation, but myself and others would argue that the fact that our perspective shifts, I mean, not mine, because I'm not, old, but later, experience and wisdom, we know that with aging, wisdom grows. And we know that the role of the aging adult, it's very important in terms of purpose and meaning to see themselves as a savant or a seer or a curator, et cetera, et cetera. So this simply points out that, in a lot of older adults, with perspective, with wisdom, with experience, they have a bigger picture, a broader view. This too shall pass. Hey, I've been through this, and this, I can get through that. So often I think that there are older adults that have that resilience due to wisdom. Perhaps we don't see them particularly in psychiatry because we see the elderly, not the welderly. The other issue with aging, of course, are issues of physical decline. Becoming more anxious simply about the illness would be a natural thing. Falling phobias can be an issue for sure. Anxiety is worse in people with obsessive compulsive personality. And notice the personality disorder. It's the sort of the type A, perfectionistic, always on time, things just so. It's not the obsessive compulsive disorder, anxiety, germ phobia disorder. But you can see how people who are rigid and need things just so and need to have some control don't do well with aging necessarily because you can't control aging. You can't control the slings and arrows of aging. People with hypochondriasis obviously can get tied up more and more with as they have more illnesses or more even just vague symptoms. They can get really ramped up. And mild cognitive impairment in some, of course, unleashes a great deal of anxiety as they fear Alzheimer's. And then I would argue there's less anxiety with fear of death. There's actually data on that the older adult, almost paradoxically, has less fear of death than young ones. And the borderline personality thing is that the extreme symptoms tend to fade away. So, the 30-year-old borderline who jumps on the table in the hospital and breaks the old fluorescent, the cover of those old fluorescent light bulbs and threatens to cut herself with it. I mean, you don't tend to get that in the older adult, right? Is simply what I mean by that. Confinement syndrome, this damn virus and confinement is a huge issue in the isolation. And so this was a slide just talking about all ages and risk, who's going to have struggles more. But I've underlined at the bottom, the decrease in social engagement is real and is a huge issue with the older adult. How people do depends a little bit on how their social network was pre-pandemic. But of course, as I'll talk later, the older adult struggles with connecting. If they're not virtually able to connect, if they are able to connect, often their friends are not. So there's a real issue on that, and we need to problem solve that. And also the couples, except the families that have a lot of discord pre-pandemic struggle as well. And so, as we know, the person who is a caregiver of somebody with Alzheimer's and more locked in their house can be very difficult for both of them. So going to the DSM, just a few examples. So panic attack in the older adult. We don't see new onset panic disorder. We don't usually see new onset straight up panic attack. If a panic attack happens, it's important to rule out organic causes first. why the sudden surge of anxiety, for example, heart attack, angina, etc. The sympathetic or adrenergic response tends to be less robust than in the young person. So often the physical symptoms are not quite as seemingly deadly to the panic attack in the older adult, thankfully. But on the flip side, often in that panic is sort of an existential, meaning of life. What have I contributed in my life? What lies ahead in death can contribute amidst that panic attack. Social anxiety disorder, unusual to have a new onset. It works both ways. As we age, often there's more isolation, and certainly social anxiety disorder would contribute to that person becoming more isolated. They're just as comfortable to not be wildly socially, especially in groups or unknown individuals, interacting with unknown people. But also what's interesting is they actually do better through the pandemic because they're less distressed about not having group things, because that was stressful anyway. So it's like, okay, good, nobody's bugging me to do group stuff. This is awesome. And then generalized anxiety in the older adults, again, it's usually more chronic. It's not usually new onset. Often you'll have worries, including the medical condition, as part of the several areas of worry. I won't go on and on about it, but I mean, if it's solely a concern about the medical area of worry, then it's more of a illness, anxiety disorder, what was used to called hypochondriasis, etc. But you can see how in the midst of several domains of just chronic worry, a high baseline of worry, medical would join in that group as one gets older. And you often in the older adults see new onset worry, but not the significant impact on functioning. So maybe not quite meeting criteria for a disorder, but certainly an issue of worry that one needs to try to address. And now let's talk a little bit about the people with dementia, okay? And so this is simply saying, okay, you think confinement with older adults not demented is bad, try being demented. And as you know, we're seeing all kinds of things in blue and more. So it's a tough one. It's a real tough one. The impact of dementia on anxiety, specifically, I just put this to you, remember that it's me talking. The issue is, I'm going to talk a little bit, a few slides, and what I'm talking about is the symptom expression, and I'm going to focus less on the cognitive. I have some hidden slides that'll be part of the archive slides that talk about, bipolar disorder on cognition, and does ADHD risk, is it a risk factor for dementia? But I left those out for today, but it will be in the slides. So this is looking at the psychiatric. So is there cognitive change because of the psychiatric disorder is the question I'm going to sidestep. I'm going to look more at the psychiatric diagnosis. Does the psychiatric diagnosis obscure the diagnosis or affect the course of dementia? I'm going to look more at BPSD, behavior, psychological stuff along the journey of dementia. And then the question, does dementia affect the psychiatric symptom expression? I'm going to look at that as well. So anxiety disorders, this was supposed to be blanked, but no, there's no association in anxiety disorders except PTSD and cognitive decline. In terms of generalized anxiety disorder, the symptoms, the main issue is the paragraph in red that says that as people dement, those with generalized anxiety get more anxious. They don't feel anchored. They have a propensity to worry. And so they start worry about the dementia. And what happens, especially in the private home setting, is that the dementia is missed and everybody's focusing on the anxiety. I remember years ago, a husband saying, my wife, always found it soothing to do laundry. And so she'd get anxious and I'd tell her, go downstairs and just do some laundry, honey, trying to be helpful. And as we started to understand there was dementia in this story, it turns out if you watched her do the laundry, she'd get really frustrated by trying to remember how to use the washing machine. So in the early days, picking up the fact that this is a signal of a declining cognition becomes important. And even in long-term care, you've heard me talk about the anxiety feels like the person is kind of, quote, lost at sea, as one demented person described it, that they're not anchored. So you hear a lot of, tell me what to do, what am I doing? Tell me what to do. Where am I? What should I do? And often that is in the person who has had a lifelong generalized anxiety disorder, or a lifelong propensity to worry, at least. The other thing in that paragraph just says that, if the anxiety is severe, then obviously, if you're super anxious, you can't concentrate. If you can't concentrate, you can't file the information in your brain, and therefore you won't remember it, which is different than Alzheimer's, that says that, you can file it okay, but like you can take it in, but the filing cabinet's broken, so you can't find it to take it out. And then the other issue is, does dementia affect psychiatric symptom expression? Again, it's colored on both sides. So the takeaway message is, if there's increased anxiety, ask the question, is there worsening cognition that's driving this? I will talk about treatment just with this one because it's so common, and that is that, especially in the early stages, somebody's come and describing maybe some memory stuff, but a lot of anxiety. Usually what I'll try to do is anchor the anxiety first. And sometimes that uses medication if it's true generalized anxiety disorder, and then ask the question, okay, how's the cognition? How's the functioning? And if it's still evidence of dementia, then it's about starting to work with the family about approach, etc., starting to decrease the performance demands. Remember, in that pieces mnemonic, the C indicates capability, which is not the legal capacity, it's the ability. It means meet the person where they're at. And that's true in the long-term care facility. Maybe they've been there a year, and initially they were able to help the recreation people set up groups, and that gave them some purpose and meaning. But now when you ask them, they're more anxious or irritable, and it turns out that their cognition has slipped, and they have more anxiety as a response, and so it's sometimes also I'll recommend early on to use something like an Aricept, Reminil, or Exelon to help the patient become a little more anchored in the context of dementia. You'll hear me talk later about, the person that's wandering and saying, tell me what to do in the long-term care facility. At least try to put yourself in their shoes. Imagine what it's like. What would you need? What would you need to hear? What kind of interaction would you need to at least feel reassured? And then social anxiety and dementia. Does dementia affect psychiatric symptom expression? What's interesting is, it's a blessing as the insight deteriorates, then you will see less anxiety about their performance. They'll kind of forget that they worry about that stuff. Or paradoxically, family will comment on how they're suddenly so comfortable in crowds because their frontal lobe is damaged a wee bit and they become disinhibited. What I want you to think about, though, is that on admission to retirement home or long-term care, ask about, the comfort in social situations, because again, if you put yourself in their shoes, this is a socially anxious person, terrified of being evaluated, et cetera, they don't want to be, enthusiastically in times to join a group or to be part of this or that. They need to sort of settle in. They need to have respect that they need to do retirement home. And then they need gentle reassurance. You know what? I know you like music. Why don't you sit at the back of the music group thing? And you can leave if you need to. So you need to sort of recognize and then reassure them that they're not going to be in the front. They're not going to be asked to run the group, et cetera, et cetera. Post-traumatic stress disorder, it's not part of an anxiety disorder. If anybody cares, it still is what it is. The issue is that, sorry, again, I did hide this slide, but I think it didn't save well. But this is high-tech stuff. Yeah, there is some impact on cognition. The issue, though, is what you often hear me talk about. As the progresses, there's a propensity to current and past, and that's the flashback to the past, the misinterpretation, especially during care, of course, that they are being sexually abused again, or the institutional setting, as in the red there, is reawakened as they're sort of in an institutional setting, or the dining area flashes them back to like a TB sanatorium or something. And you guys have seen that, but it's very important. And that's where I think reality orientation is a important thing to add in. You know, it's 2021. You're doing well for 86. Wow, can you believe you're 80? You know, just try to bring them into the current. And that's the red in there. The other thing is remove any cues to sort of the past, what might perpetuate the flashbacks. And I think you guys are getting really good at that, especially during care. This is just a slide. I won't dwell too much on this, but what can look like an anxiety disorder? And in that is the agitated major depression, the ADHD, attention deficit hyperactivity disorder, bipolar 2, so hypomania, not wild, expansive, huge manic episodes. And also, oh, see, it didn't save. I also added adjustment and reaction with anxious mood in there. So that's the person that comes into your facility. It's normal to be anxious for the first 6-8 weeks, you know. We don't need to slap them on medications. We need to understand, do they have an anxiety disorder that's not addressed? And if they don't, how can we support them through those first, the first month or two, and normalize their anxiety? And then so that's the adjustment disorder with anxiety disorder. And then the normal reaction to a significant stressor is not even a functional impact, just it's normal to be anxious with a stress, and that's fully normalizing. ADHD, real fast, the blurting in ADHD, the risk-taking, the impulsivity in ADHD can be in the red. It can be misinterpreted as frontal lobe dementia. In fact, if you look at something like a frontal behavioral inventory and an ADHD scale, like the fast mind scale, you'll see overlap, right? So sometimes you can have both. But it's just important to realize that sometimes in the blurting, if we do a careful pre-morbid history, there's undiagnosed ADHD that's really driving that, right? And of course, the issue of especially in home visits. So the second last line there, if their house is all disorganized and their attention to detail is not that great, maybe there's lifelong ADHD there, and it's not a change that indicates a serious safety risk and diagnostic of a dementia, for example. And of course, we also have had times where we have been asked in home settings to look at memory. And in fact, we've diagnosed ADHD, and it's not a dementia, it's ADHD. And sometimes people do much, much better. Sometimes they have both. But sometimes a careful introduction of Ritalin, because it's short acting, can really make a difference in these people. The other thing is, just for fun in red, set shifting. So ADHD is known to not set shift. They focus on one thing and it's hard for them to sort of shift to the other real fast. Well, guess what? Perseveration is the repetition physically or verbally. It's a frontal lobe function, and set shifting is part of that. And so ADHD people won't set shift all that well either. So once again, before we call it frontal lobe, let's get a collateral history. And that just talks about how you do have success. And then bipolar disorder. All I want to say about sorry, again, I hid this and then it didn't hide, but the issue with the bipolar is this, that people who have a lot of frontal lobe disinhibition, so real frontal lobe syndrome, like a stroke or something, or a frontal lobe dementia, they can actually look like mania at times. Also, bipolar 2 doesn't have to necessarily be a high of euphoria and expansive mood. It can be more a cluster of irritability and intrusiveness and stuff. And so sometimes we'll see cycles in a dementia. I just had a case of vascular dementia that reminded me that vascular dementia, 40% have cycles or fluctuation in their confusion over days. We know Lewy body can have that too. This is more cycles in mood, but in the demented, sometimes it overlaps. My point is that sometimes when we're seeing cycles, especially of irritability, we need to go back and get a collateral on, what are we missing a bipolar 2 lifelong? And there have been times when I sort of think, gee, I wish I had met this person 40 years ago, because they've clearly had bipolar 2 all their life and it's affected them. And then what about interventions? Well, this is the famous placemat, and this you're all aware. It's on the SGS website. It's dealing with, and I hope that it wasn't cut off, but it's dealing with the escalating behaviors of anxiety and agitation, etc. And this is really in the moment what you do, and I'm not going to dwell on it too much, because it's really talking about in the moment and considering whether to call a code white and looking at the care. It's really good, but I'm going to more focus on the blue box and then talk a little bit about other interventions more past that moment. So I certainly endorse this. I think it's very useful. I think the blue box is very good as well. And this is the blue box that is kind of, yeah, I know that, but it's always good to reread it and just think about it. So I'll give you a moment. So yes, we all know that. I think, though, as I say, it's important to remember the importance of body language, tone of voice, smile. Even though you're freaking out that, oh my gosh, this is horrible. There's this person's getting really agitated. Do your best just to keep calm. The other thing in terms of approach is so significant. I'm going to talk real quick about some issues of approach, or ways to think of approach from a psychiatry perspective. And so approach is a lot of these things. It's not just what we say, right? And approach also is influenced by things. Don't worry, there's only two slides on this. But transference. So Freud was good for something. He did have an interesting thought about transference, which is that unconscious thing that is sort of in our minds and can get influences on how we interact in the present, because of sort of that old baggage of transference, of infantile sort of wish stuff about love and needingness and abandonment and stuff. And so we can see sometimes that repeated in similar interactions. So that's the concept, that we have baggage, we have conscious real world stuff, and we kind of have this unconscious world too. And then there's the countertransference, which is a little more complicated, but it's the therapist or the workers, their own reaction to that patient, but we're not aware of it. So we might think that that person's mean, but we also have this unconscious reaction to that meanness as well, and I'll talk about that. And then there's also the real relationship as well. So what I'm getting to is, somebody hits you, it hurts. It hurts emotionally, maybe. It annoys you. It angers you. There's a real reaction for any human. And then there's the issues of the countertransference and the transference, which tells us that, if I was abused by my father as a kid and I'm hit by a male resident, I have the right, it hurts, it's not right, it's me, I have a right to real reactions and the real interaction. There is a chance, though, that I also have this unconscious reaction, my, child mind, vulnerable child, remembering that and having a stronger reaction, a stronger anger. So it's not to say that you're bad, it's just to say be aware of it. Sometimes our reactions are overdetermined because of that unconscious sort of dance. I'll leave it at that. Another nice way to put it is that we all carry baggage with us in little suitcases along our life, and baggage can include this kind of stuff. Maybe we give, because of our baggage, our stuff, we don't attend to somebody as much as maybe we should. We assume that they're assholes, or they're super manipulative, and maybe they are, but it really pisses us off more than perhaps our colleague. Or we give too much attention. We get sucked into, oh, you poor little thing. Okay, and I've had over the 23 years, sometimes back in the day, CCAC, one very lovely woman, but she actually went to the person's house on the weekend to help them move, and then the person was borderline, and so then they were accused of stealing. It was a bloody mess. So we have to be careful. That's all I'm saying. Just be aware. We don't have to be perfect. We just need to know our blind spots. Bottom line is behavior has meaning. You know that when you look at your residents, what's driving this, what is the meaning of what they're saying, but also our behavior has meaning too. So going back to non-pharmacological treatment, that blue box I think is important. The second line here is really important. Imagine what it's like for that resident. So, easiest maybe is that person who's a worrywart and their memory's going, they're not sure if they're in their living room or they feel like they should be doing something, etc. Especially the really fancy retirement homes sometimes feels like people's living rooms. And so they kind of, I think, feel lost, like, where am I? Oh, is this my place? Should I be dusting? And so try to just be like the yoga bee in their shoes, and just sit there for a minute. And that, I think, helps make the interventions more useful in an individualized sense. And distraction in terms of anxiety is a really core thing, as you know. So I thought I'd talk a little bit. I sort of took the time to do some research on certain structured therapies, but I'm going to comment on the pros and cons. So cognitive behavioral therapy, again, this will be archived so you can read all this stuff. Yeah, there is data. Good data for depression. I'm talking older adult, right? Good data for depression. Some data for anxiety. For example, long-term management of generalized anxiety up to 1 year was effective. The first line there says that if you add the relaxation training component, it's particularly effective with mild anxiety, and some recommend using that at the beginning of a CBD course of treatment. This is assuming the worker is trained in CBT and has the time and the mandate to do CBT. For example, from my perspective, the actual mental health team nurses, we don't do that because our mandate is consultation, for example. The other issue, though, with CBT is there's less data in dementia, and certainly I would advise, even in the home visit setting, to have hard copy to help them remember some of the techniques and the recommendations of how they do their homework, etc. Oh, that just reminds me to shut up and pause. I have 20 minutes, and then the computer explodes. Interpersonal psychotherapy has some data in older adults and anxiety. More on, that's the last line, it may be efficacious, quoting one study, for example. There's better data in depression. And the interpersonal therapy, you'll see, in the experience of somebody depressed, struggling with a new diagnosis of dementia, could work beautifully. Again, this is not necessarily you can just run off at the long-term care facility and do this, but I was asked to talk about non-pharmacological treatment, so here you go. Problem-solving therapy, there is data. I think some were, I also talked about an adaptation of that. It's called problem adaptation therapy. And so I think at Waypoint, there was some training a few years ago, and I think some of the BSS teams have some training in that, but there's different formats. It's different than CBD. That second line talks about there's less emphasis on challenging those automatic thoughts and doing a lot of behavioral activation, but it's more solution focused. Better data on depression, for sure. And then this is an adaptation of it, and it was really developed for depression and dementia, right? And it worked fairly well. There, I've quoted the study there at the bottom. Notice the last line that those considered treatment-resistant depression did the best with this PATH stuff versus just normal supportive care. Now, I will quickly tell you, those who know me know that sometimes I complain that not all depression is major depressive episodes. So in that, the treatment-resistant depression, everybody's calling them depressed, oh, the antidepressants are not working. Well, maybe that's because it's not major depression. Maybe it's a family issue, a marital issue, substance abuse, personality issue, et cetera, et cetera, et cetera. Mindfulness, I tried to look at the data. Admittedly, I didn't look at the world data. More case reports, and a recent review, which I've quoted in tiny letters there, because when I made it bigger, the top went smaller. They were less impressed with the using mindfulness-based cognitive therapy. But the second line is my own experience. I think if you have somebody who knows what they're teaching, and the person who is taught understands the deep belly breathing, and it gets better and better at sort of letting the inner thoughts drift by, they seem to do better with their anxiety, and they seem to do better with their sense of well-being, at least in the moment. And so I am supportive of the notion of mindfulness. I don't pretend to be an expert in it. I still have good days and bad days when I remember to do it. Some days it kind of works. Some days it works. Some days it's like, oh my God, my mind. I think it's worth continuing with for sure. In dementia, there are challenges. What about EMDR? Well, again, I didn't do world literature research. There's more data on the depressed older adults, not as much in dementia. There are some case reports in depression and dementia. Again, I mean, doing those steps and stuff may be tricky. The person doing the therapy has to be fully trained in it. But there is really good data on PTSD, et cetera, of all ages from what I can see. But that was not including people with dementia. They were just excluded in most of the studies. This is an interesting article that I will just springboard off of just real quick. So in general, about pharmacological treatment, there were a few studies identified anxiety at a baseline. Okay, so if you're going to say, does this therapy or intervention work in anxiety? Well, a few of the studies actually identified and rated anxiety at the baseline. And rarely, actually, it was just the music studies that measured anxiety as a primary outcome in terms of statistical analysis. So that's bad. All of them have different methodologies, scales. It's the same old. Now, with anxiety, I did read that it's difficult to separate the domains of anxiety, agitation, and depression. And so that's probably why they chose not to just track anxiety. And even the RAD, the dementia scale used in dementia around these woods, there's an overlap with depression in its analysis and what it's picking up. So some people muse that maybe distress is a better global construct in terms of constructing research. I think I've said this before, I'll say it again, understand the lived experiences, right? Walk in their shoes, use your imagination, and really just put yourself in their shoes. Ken LeClaire talked about on intake, we should be asking the person and the families, what did they love to do? What did they hate? And so for me, for example, would be bring me back to mountain biking or, a favorite trail of mine or, skiing with the kids or something. So we need to know what settles and we need to use that. What about music therapy? But really quickly, some promise, the last line, some promise in decreasing anxiety. In one study, it was questioning, is it the group interaction, the music? I think in the moment we see that music helps, and if anything, they did well to use primary outcomes and did have some data in the smaller studies. Activity therapy, there was limitations in the analysis. So the two studies that said no statistically significant, that's SS difference, it wasn't that consistent across the studies. If it's done right, the money and time in terms of really engaging the person in pleasurable events or activities, maintaining with them, being engaged in it with them is a problem. These three domains, again, methodological issues, so it's hard. Maybe some positive results, including decreased agitation. We know exercise has a lot of enthusiasm, especially in the adult population, which I believe is true. Other stuff, you know, at the bottom, again, it's more, the studies are more around agitation or quality of life. So it's tough to say.
Excuse me, Dr.
Thank you. Thank you. Yeah. The other thing I thought I know expert, but I thought was fun. You can Google companion or social robots, and you can Google, humans, and there's human and animal, right? So you know, again, there was no statistical significance in meta-analysis. Some of the studies were older. And so I suspect the robots have improved. The vast majority were animal robots. One famous one was a seal, go figure. I think that was in a country that likes seals. So there was some decrease in the scores and stuff. And I know that we find that even those furry, you know, animals that their bodies move can be very successful. So I put this down for interest, and I put this down in terms of the future. In that is the human robot. There's ethical concerns, of course. The question of, well, they're not getting real human interaction and touch. There was a study that mentioned that when you ask the user, the older adult, they wanted more eye contact, more accurate speech and stuff. And then this is a big one, virtual and augmented reality, including, I've talked about holograms. Wouldn't it be nice for, you know, somebody who's looking for their wife to have the hologram beside them, assuming they're demented enough to not realize it's a hologram? And I always say, if it's me, make sure it's my second wife, not my first wife beside me. Just kidding. So that ties me back to really, after all of this, I think this is the key. And then as I was writing this and thinking about it, I thought, you know, how do we improve our game? You know, can we make an inventory of creative ideas, not necessarily therapies, but just things that have worked with people? Like, you know, somebody thinks that person's their spouse, and instead of using meds, let's put a ball cap on them or put a wig with power of attorney consent, and it works beautifully. Can we continue with our outcome measures to see that we're making improvement? Maybe we could educate ourselves and pilot a specific therapy or some kind of an algorithm of, you know, music and then this with outcome measures ourselves, you know. And can we keep up on the technology and virtual strategies? Maybe we don't have the funding, but maybe we could make a case to get the funding and it'll be part of a study. And I rely on the younger folks in the audience to really pursue that. So I'm going to shut up and we'll move to questions. Thank you, if anybody's still there.
Thank you, Dr. Daniel. I do have one question. Do you have any advice for teams or staff to support residents with anxiety during COVID-19, given that everyone's anxiety is heightened at this time?
I guess that's the question of 2020 and now 2021, eh? I guess really my first thought is pray. I think it's hard for everybody. I think that, you know, if there are creative solutions, then they're beaten down by necessary restrictions. So I think it's very difficult. It feels like the role of the essential caregiver, that is the family member, is important to try to preserve with careful PPE and careful advocacy for funding for PPE. Because not only is an extra pair of hands, but it's really really soothing and targeting that isolation. I know there's been some events where, you know, patients come into long-term care and quarantine, and the family member has come in with them to quarantine. I think it depends on the family member, but that would be one thought. I think, again, really trying to utilize virtual methods is really all that we can do. Other than that, I don't have a miracle solution. It's the big problem, and I would actually ask the group maybe to start typing about their thoughts about how they would better answer that question. To be honest, go ahead, start typing.
There's one comment to add to that. Someone is part of the COVID Companions. It was set up through a local Facebook page where she lives, and they have partnered volunteers to pen pal with residents who signed up for it.
Yes, thank you. I've heard about that, and that's awesome. I think about Maureen Corbett, who is doing, I think, more in the community, right, like personal homes, but being mandated to try to link with people and engage them and get them socially involved. Is there a need for that in long-term care, and where does one find the funding, or is it other groups such as church groups or seniors groups that can provide assist with that?
There's also another group that I noticed, Facebook group that put out there if families with children could go to long-term care homes and build snowmen outside the windows of the residents so they could actually watch the children play and then have a snowman to look at.
Awesome. That's cool. And one can build on that. I don't mean the snowman, but just kids, even singing or something and doing all that stuff too.
There's another comment that they have seen some really good outcomes with iPads and having families FaceTiming residents.
Definitely. Now, of course, some it doesn't work, some level of dementia or comfort, even my mother said she doesn't like doing video stuff because she finds the screen, confusing, and half the time she's kind of like that on the screen. She just prefers the old-fashioned phone call, but, and she's not demented, or maybe just tiddly touch. Next question.
I'm just moving to the chat. Someone has said, thank you so much for the presentation. I appreciate that there's a transition period from our new admissions into long-term care homes, which can occur for weeks at a time. We all know the demands frontline staff struggle with on a daily basis. So while we know that supporting and placing yourself in their shoes, do you have any suggestions to support our new admissions, especially when they have to stay on a 14-day isolation in their rooms?
Again, I am not privy to something that's worked fantastically well, nor have I heard it from like the RGPO group or things like that. I feel as impotent as you do in terms of really having a good solution to the problem. I think I'm stymied as well. I think just trying the best to remind people of what's going on and keeping them distracted is the best. But the flip side is, early on, I was asked to, what suggestions for staff, because it's you guys that are burning out, and it's a mess. So I think in terms of staff wellness, it's like in the airplane. You got to put your own oxygen mask on before you help those who need the help. Otherwise, you'll pass out and not be able to help them. So there's lots of avenues of suggestions, everything from Waypoint to your college associations giving recommendations, the Ontario government giving recommendations on how to take care of yourself. So I won't repeat all those, but I'm curious if anybody else has suggested an innovative idea with this issue. Beth?
There is one comment about the use of weighted blankets, that it's been used in homes and they're very effective and important to ensure that the resident is getting the right size of the blanket. Yeah.
I guess the essence is trying to help the people understand why they're restricted, isolated in dementia, The other is to maximize any kind of contact they have with their social network. It's very, very difficult in dementia, and then spending the time dealing with their agitation. So I think using creative solutions for the agitation and distraction, etc. I think sometimes we have to use medications. Again, we don't try not to jump to them first, but we want to balance that level of distress in somebody that doesn't understand they're isolated, doesn't have the capacity to remember, even if there's a big note in big letters on the door, Spanish flu is back again, kind of thing. It's tough.
There's another question, Dr. Daniel. What are your thoughts on an essential visitor being an intervention to assist with reducing anxiety behaviors? Many long-term care homes barriers at this time.
Yeah, and I get those barriers. I'm not criticizing those barriers. Sometimes family members can get too intrusive and sort of keep the people from the programs pre-pandemic and stuff. I think now what I'm hearing is that generally they play an essential role, no pun intended, both another pair of hands, but also a soothing influence on that person. So I'm a big fan of them. I realize that PPE is an issue, but I think that if one can outweigh the PPE concerns, and I think it's worth it.
There are no more questions in the question and answer box. So I think that comes to the end of our questions, Dr. Daniel.
Well, I'm sure you're doing outcome measure on this, and be honest with your feedback because it helps me get better.
There will be a poll, yes, and we'll be able to let you know the results of that. So thank you, Dr. Daniel.
You're welcome.
On behalf of the North Simcoe Muskoka Specialized Geriatric Services team and all the attendees, I'd like to thank you for this presentation. It was very insightful. The information you shared today on anxiety in the older adult has been very helpful, and I'm sure will definitely be something that can be part of able to implement into everyone's everyday practice. So thank you for that.
You're welcome. Thank you.
We'll now be launching 4 poll questions related to this education session, and we ask that you take a moment to answer them for us. Please scroll down to view all the questions. And if you could also place any suggestions you may have for future education or topics that you would like discussed in the chat box, we will take note of those as well. I'd like to remind the attendees that if you'd like to obtain a copy of the recording of this session, please reach out to your RN team lead. And our next session for the Leadership and Innovation in Long-Term Care 2021 event will be held on Wednesday, February the 10th at 1 p.m. We have the pleasure of hearing from Heidi Flynn, who will be speaking about music therapy in persons with dementia. In addition to this education, SGS is offering education over the next 3 months related to COVID Series 2021 Winter Survival Kit. The first session will be held this Friday, January 15th at 8:30 via Zoom, and it will feature Maureen Corbett, recreation therapist for NSM SGS, discussing maintaining social engagement during lockdown. Please check the chat box for the link to register, and please note that registration is required to attend the session, although it is free registration. We hope you will join us for this next session. We thank you for joining us today, and we look forward to seeing you next month. Have a good day.